So I'm going to ask my colleagues, Dan, Osama, what your initial reactions are and how the publication of REACH2 has changed your practice for steroid-refractory acute graft versus host disease. Dan, you lead us off?
I sort of, I have to say that the REACH2 sort of confirmed what a lot of us were expecting to see, because the all the results here and there that we were seeing preliminarily look pretty promising. I started, to be completely honest, starting ruxolitinib as second-line therapy for steroid-refractory acute GVHD a little before we had this confirmation. It did change my practice, because up until then, my go-to choice, particularly for skin and liver, was extracorporeal photopheresis, because that's, the technology that I was, and the treatment that I was more familiar with. Now, with the advent of ruxolitinib and the approval, I feel that I have a second choice that is just as valid and probably more validated, at this point. And needless to say, it helps a lot from an insurance perspective too.
Right. Osama, your thoughts on this compound and how has it changed your practice?
So I agree with Dan and you, Corey. We have to remember that the approval of ruxolitinib almost a year ago for acute GVHD, steroid-refractory acute GVHD, was based on 41 patients, efficacy in 41 patients, which one highlights the unmet need in that arena. But still, with all the variables in recipient conditioning, patient variables, disease, many variables, it's impossible, to tease out response and efficacy in 41 patients. So when this publication came in recently, I think a month and a half ago, in New England Journal of Medicine, I mean, we were all most of us were part of this trial, so we were in the know. But it's very, it's good to have finally a phase 3 trial. The other point is, even before the approval of ruxolitinib and the publication of the 41 patients, there were 2 retrospective larger reports, each one reported on almost 100 patients. So again, just like Dan said, we were way before the approval, we were giving ruxolitinib in that setting, but you really have to go through hoops sometimes with logistics and insurance. So it's good to have solid data.
What were you using before ruxolitinib? What was your go-to second-line agent? Was it the same in all patients, or did it depend on the clinical scenario, like Dan mentioned, that he used ECP predominantly in cutaneous and hepatic disease?
We are all products of our experiences or post-traumatic stress syndromes that we have from our patients who sometimes do not do well with certain things. So my early experience was really marked by losing patients from lower GI acute graft versus host disease. So my first choice for skin, GI, and liver were, if no clinical trials were available, and we've done mesenchymal stem cells, we've done many clinical trials, was for ECP with or without something else. And I've always been a believer in ECP, just because it's not pharmacologic and, as you said, does not affect blood counts. It's, of course, logistically, it's difficult for patients to have a catheter and come twice a week sometimes. But short answer, in if clinical trials, number one, no clinical trials, ECP with or without something else. I'm also a fan for the GI of the local steroids, for the upper piclomethasone and budesonide.
Mm-hmm.
So, I use that, liberally. That's basically my practice.
And it's interesting because we use very little ECP here in our center for steroid-resistant acute graft versus host disease. And the difference in our practice is not based on data. It's simply based on this is what we do here. And we do have access to ECP, but it simply was not part of our culture.
Yeah, your routine. Yeah.
But it was freely available, and we do use it sometimes, I will admit, particularly in patients who we are more concerned about infection, because as you mentioned, it's not immunosuppressive. But again, I think the three of us all agree that clinical trials are still the mainstay. It is possible now that ruxolitinib becomes the control arm for these clinical trials as new agents are being developed. And I think we'll all agree that having an agent with demonstrated efficacy as the control will make us much more comfortable testing new agents, knowing that the control arm is going to be getting active therapy, and we now have a higher hurdle to get across to get new agents approved.
Right. And I wanted to add, my shared practice with you, Osama, of oral beclomethasone, which actually before REACH 2, oral beclo was probably the only agent with a randomized study that you could, base your practice on. And so, I mean, I do use it for in situations where I can use it.